Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
The next is a 64-year-old woman who has a prior smoking history, 20-pack years, diagnosed with a stage 1 adenocarcinoma of the left upper lobe that was found incidentally in a hospitalization due to a hemorrhagic CVA 3 months prior. And she has actually minimal medical history, just hypertension, but is still recovering from her CVA of the left basal ganglia. And she has some residual right-sided deficits, motor deficits, some language deficits. Her performance status right now is 2, but that may be a moving target going in the right direction. And if we can turn to the imaging and some other details, we'll then be asking the question of surgery feasibility and timing of surgery versus radiation, given her being in the wake of still a recovery from this event. Okay, Dr. Ginsberg?
This appearance on imaging is classic for adenocarcinoma. What we see on the left-hand side is the CT axial and coronal sections, which demonstrate the spiculated 1.6 centimeter nodule. You see the spicules and they extend to the pleural surface with a slight pleural retraction, and mildly FDG avid with an SUV of 3.0. No other enlarged lymph nodes or FDG avidity seen elsewhere to suggest any distant disease.
Okay. So a few details we've seen. Imaging, the chest CT and a PET CT that confirms uptake with an SUV, max SUV of 3, but no evidence of more distant disease. A biopsy shows adenocarcinoma with TTF1 positive, napsin positive. Did not have molecular testing, and we have the pulmonary function test you can see here, FVC 2.65 liters, FEV1 1.7 liters, the DLCO shown. So we're left now with the question of whether you feel, Dr. Force, somebody who is still in recovery from a recent stroke and has some residual deficits, performance status 2, and you can see the overall imaging picture, the pathology and the pulmonary function. How much of a concern is this, and would you say that surgery is completely feasible? Would you favor, if that is the case, proceeding soon or any kind of delayed approach for more recovery?
So I want to I guess address the last question first. I'm not a big fan of delaying treatment to any significant time period once you have a diagnosis. We have some retrospective studies suggesting that if you don't treat or operate within 8 weeks, then the prognosis starts to worsen. So to me, when I'm seeing the patient, I mean, if you're talking about waiting a week or two, but if we're saying that she needs a couple months of recovery, it makes no sense to me to wait for treatment. So if she can't have surgery, then she's not going to have surgery right now, and she's going to move on, and I would refer her for radiation therapy. I saw an exact patient like this a month or so ago, and I referred her for radiation. It really depends on the severity of the deficits and a discussion with her neurologist. So if she has weakness, if she's somewhat hemiplegic still, if she has a hard time standing or walking, those patients who are really non-ambulatory are very high risk for surgery. They have a hard time recovering. And even the stress of surgery and anesthesia can exacerbate their symptoms early after a stroke. So if we felt that, in talking with her and her neurologist, that she was high risk for jeopardizing her recovery, then I would, even though she otherwise appears to be a surgical candidate, I would refer her for a localized stereotactic radiation.
Dr. Robinson, how much do you consider her case to be right in your wheelhouse versus one that you would be inclined to at least strongly consider surgery instead?
I think Dr. Forrest nicely summarized the issues. This is exactly the type of patient that often ends up coming to our clinic. And I think it belies the point that I mentioned earlier, which is that there's no single stratification tool that allows us to accommodate for all the different scenarios. We often get quite obsessed with PFTs, but here's the situation where that's not the primary driver. The other thing that would make me a little bit more excited about possibly offering SBRT to this patient is that, unlike the prior case, a large squamous cell carcinoma, this is a relatively small, presumed low-grade adenocarcinoma. And this is a situation where we'd expect that our primary tumor control rates are very high, and then therefore the net benefit of some of the other issues we talked about becomes a little less clear. So I think that this would be a favorable candidate. I echo Dr. Force's concern about not wanting to delay therapy. I do think that sometimes that happens regardless, meaning that you often find in these low-grade lesions that they've likely been present for quite some time, and they've slowly navigated through the system. So you sometimes wonder if intervening at this moment versus the next. But once you have a diagnosis, once you know what's going on, there doesn't seem to be any real reason to delay.
So, and that would apply for radiation as well as surgery. If you're going to, if
Right.
you can treat as soon as you can. Right. Okay. Any other comments? Otherwise, I would just summarize and say that we really have good consensus here that while it's worth an evaluation by a thoracic surgeon to consider surgery, and it is certainly a possibility, it really depends on neurologic function and overall functional status. And if a patient is not very ambulatory, that's going to incur greater risks. This is also a setting, this patient has a cancer that appears to be one that is very amenable to radiation-based treatment with an anticipation of good success. So that is not some a consolation prize to back into by attrition, but rather a very viable alternative. Okay.